Hello, everyone, and welcome. I am Kim Nitz, a program manager for the Parkinson's Foundation. We are passionate about helping each person with Parkinson's to live better, so it's great to be reaching so many of you today in our virtual meeting format. We have participants from all over the state of Kansas and beyond. We welcome you all. Please note, attendees will be muted and off camera during today's presentation to help reduce background noise and echo. Today's program will offer important information about Parkinson's disease, from who gets it to the symptoms, treatments, and therapies to help manage it. It should serve as a good baseline if you're new to Parkinson's, or a good refresher for those more experienced in their Parkinson's journey. We have built in time to ask our expert your questions, so please submit those at any time via the Q&A icon at the bottom of your screen. We're thrilled to have one of the Heartland Parkinson's community's favorite speakers with us today and appreciate the great response for today's program. I want to quickly share just a bit about the Parkinson's Foundation for those of you new to us. The Parkinson's Foundation is here to support the estimated 1 million Americans living with Parkinson's disease, as well as the many who care for them and those working to end the disease. For those of you new to the Foundation, we focus on 3 goals: advancing Parkinson's research, improving care for those living with PD, and empowering the PD community with educational resources. These resources are extensive and include our website, parkinson.org, our free educational book series that you can download or order in hard copy, a library of recorded podcasts and webinars, and our hospital safety kit called Aware and Care that we will touch on later. And a great resource, if you have not connected with them yet, is our national helpline at 1-800-4PD-INFO, which is staffed with Parkinson's specialists ready to assist. On May 1st, we will host Moving Day Kansas City at Liberty Memorial at the World War I Museum, and we welcome all of you to get your team registered now. Moving Day is our annual walk event that this year will feature a car parade and socially distanced exercise to engage the community and bring awareness to PD in a safe and contactless way, while raising funds to help support educational programs, resources, research initiatives, and more. Teams also will have the option to instead participate online at our virtual Moving Day on Saturday, May 22nd. We know everyone has unique concerns and needs, so we invite you to participate in whichever way makes you feel most safe and comfortable. Then on June 12th, join us at the Jewish Community Center in Overland Park for Parkinson's Revolution, an outdoor cycling experience to generate awareness and advance our mission toward a cure. You'll find details about both these events at the links we are sharing in the chat at the bottom of your screen. The Parkinson's Foundation is proud to offer PD Generation, a national research initiative that provides genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost in English and Spanish. The goal of PD Gene is to leverage genetics as a powerful tool to help us uncover what is responsible for slowing or stopping the progression of Parkinson's. Learn more and enroll at parkinson.org/pdgeneration or call our helpline. I do want to acknowledge the University of Kansas Medical Center locally as both a PD gene testing site and a Parkinson's Foundation Center of Excellence. And before we get started, I want to thank the sponsors of today's program, our platinum sponsor, Boston Scientific, and our silver sponsors, Acadia, AbbVie, Accorda, Neurocrine, Kyowa Kirin, and Synovian. We truly do appreciate their support, which helps keep today's program and many others free and available to our Parkinson's community. You will find educational materials about these companies and their resources by visiting our chapter supporters page located at the link you see on your screen. And now I'd like to introduce our featured speaker, Dr. Mohammed Nashatizadeh. Known as Dr. Mohammed by most patients, he was born and raised in Emporia, Kansas, earned his medical degree from the University of Kansas School of Medicine, and completed his neurology residency at the University of Kansas Medical Center. After serving as chief resident, he completed a movement disorder fellowship training at Baylor College of Medicine in Houston, Texas, then returned to Kansas City in 2008. He now works full-time as the neurology attending physician, staffing the inpatient neurology consult service at KU Med. In this role, he works with inpatient medicine, psychiatry, rehab, and surgery services to assess and address the neurological issues affecting hospitalized patients. He also educates neurology residents, internal medicine residents, and medical students with an emphasis on understanding how systemic medical disease can affect patients neurologically. Dr. Mohammed is a great supporter of our Heartland chapter and recently joined our advisory board. Now, just one more quick note to our audience. We will be sharing a recording and an electronic copy of the slides from today with all registrants via email within the next week. And reminder too, we do want you to submit questions during the presentation. And now I'll turn it over to you, Dr. Mohammed, to share your slides.
Thank you so much, Kim. I appreciate you inviting me to participate. Before we get started, I wanted to mention that I'm always happy to work with the Parkinson Foundation Heartland, and I am not receiving any type of reimbursement or any payment for the talk today. You know, being able to work with people who have Parkinson's disease and also family members and caregivers is something that goes back a many number of years. I actually finished my fellowship training 13 years ago. I actually recognize some of the names of the people who are participating today. I know some of you will also be listening in later. So a lot of what I'm going to cover today is a basic overview, as Kim said. We're going to be talking about what is Parkinson's disease, what are some of the thoughts about what may contribute or cause Parkinson's disease, what sort of symptoms people have, how do we actually manage the disease process, and also a little bit about the types of research projects that are going on and the future scope of Parkinson's disease. So I know a lot of times when people are first diagnosed with Parkinson's disease and their doctor tells them, well, I think you may have Parkinson's. This can be a real setback, as people may have some thoughts or experience or ideas on what Parkinson's disease, but sometimes they end up being very surprised about what that may mean for them or how it will affect them. There are some things about Parkinson's disease that are very well known, and it's important that we start with just that overview. Parkinson's disease is a progressive brain disorder. So unlike a person having a stroke or a head injury where they suffer a setback and then they'd either naturally improve or recuperate from that, Parkinson's disease is chronic. It's progressive. It gets worse over time. Most people, it can progress very, very slowly. It's usually over years to decades. There are some people, for various reasons, who can progress more quickly, but that may actually point to having a Parkinsonian condition that may be different than Parkinson's disease. But over time, people will gradually get worse at a rate that is faster than normal aging. There is no cure for Parkinson's disease, but we do have many types of treatments for various symptoms, and we'll talk about some of that today. Some of those symptoms may be movement related, and some of them may also be non-motor symptoms, which sometimes are actually more frustrating for patients because they feel like their doctors may be able to address their movements pretty well, but they're not getting the other symptoms that actually are a part of Parkinson's disease. Parkinson's disease can also affect mood and thinking. Much like any brain disease, your brain coordinates 1,000 different things in your body. And so mobility is only one of the more noticeable aspects of Parkinson's. People who are diagnosed today, people who have been diagnosed recently, people who have been diagnosed many years ago, may be at various points in the natural course of their disease. But at any point in time, whether you're brand new to Parkinson's or further along, having a healthy lifestyle and being able to continue to make some of those choices can make a difference in improving and then maintaining overall quality of life. One of the things that I see on a daily basis working in a hospital is that people end up in the hospital for various reasons, sometimes completely unrelated to their Parkinson's disease. But those medical problems that they have developed, either acutely or chronically, further add to the problems that they're dealing with their Parkinson's disease. So being as healthy as possible can make a huge difference. And this is true today as was true even 5 or 10 or 15 years ago. People with Parkinson's disease can live very well for many years, especially if they have expert care, support, and the right resources. And I think if you take away anything from my talk today, is to know that these resources are available. And you just have to be able to reach out and receive the right resources so you can get the right care that you need. So who actually develops Parkinson's disease? Well, the statistics haven't changed that much over the last 10 years. If you look at the entire population of people in the United States, we're about at 340 million people. And these are people of various ages. If you take into consideration that among adults, we have somewhere between 180 to 200 million people are adults. An estimated 1 million people in the United States have Parkinson's disease. It'll be interesting to see as the data continues to come in from the 2020 census, if that number will go up. But it's probably somewhere between 1 and 2 million people who probably have Parkinson's. Parkinson's disease can affect anyone. It doesn't matter your gender, it doesn't matter your race or ethnicity. This has been well documented all over the world. There may be certain people with different backgrounds who are genetically more likely to develop other mutations in comparison to some mutations versus others. But this is a phenomenon that happens all over the world. Most people are diagnosed when they are older, and I think many primary care physicians who may only have experience with a few people with Parkinson's disease sort of expect that this is something that happens with normal aging. But there are definitely many people who are middle-aged or younger who can develop Parkinson's disease. It's not unusual that 55 to 60 would be sort of the typical time where a lot of people are diagnosed. There are many people in their 40s. There are even some people in their 30s who can be diagnosed with this. So when you consider that, in my book, I wouldn't consider somebody as being really elderly unless they're probably 85 years old or older. But geriatrics is a field of medicine where people are 65 and older, but there are certainly people younger than that who can develop Parkinson's disease. The actual cause or causes of Parkinson's disease are unknown. And I say causes because there may be many contributing factors. This slide sort of gives an overview. Scientists believe that a combination of genetic and environmental factors contribute to increased risk. Now, I have to say, when I finished my training in Parkinson's disease 13 years ago in 2008, at that point in time, I think a lot of people thought that the genetic components for Parkinson's disease were somewhere between 5 and 10%. But I'm actually excited that we're doing some of these genetic studies like the PD gene study sponsored by the Parkinson Foundation, because when you go back and look, it may be that some of these genetic components may be playing more of a role than people thought. And so in the past, when they were doing twin studies, looking at identical twins, you can sometimes see that one gene may play a role, but sometimes if people have 3 or 4 gene mutations that may not have such an obvious impact, they can sort of add up and lead to a higher risk of Parkinson's disease, even though it doesn't seem like it's one factor. Some of this can actually be inherited, where a person's mother or father or grandparent, for example, or 2 grandparents, one on each side of the family, may pass along those gene traits, and then the combination of gene traits may be presented in an individual. Or sometimes there can be new gene mutations in the DNA where a person has no family history, and they may be the first person in their family to have developed this mutation that may increase the risk of Parkinson's. There's no question that environmental exposure can play a toxic role on changes that happen in brain cells and other cells in the body. If you look deep within cell tissues, a lot of the energy transfer that's happening inside cells involves the mitochondria. And this is a huge focus of research in the environmental changes that can lead to Parkinson's disease. As people live longer, it's not just aging. People can actually have more impaired absorption of nutrients. They may be more likely to have balance problems or live long enough where they could be exposed to one or more traumatic brain injuries. There may be also impairments in DNA repair mechanisms that kick in as people get older, and that could lead to spontaneous or new mutations as well. So there may be other risk factors that are difficult to classify, but when, the exciting thing about Parkinson's research these days is we're not looking just at the environmental exposures anymore. There's greater emphasis on what the genetic components are and what these other risk factors are, and how can we reduce risk by attacking any one of these different angles. So what actually happens in the brain when a person has Parkinson's disease? So we all have different neurons, and then around those neurons are actually different helper cells or glia, which are a lot like glue, and they provide support structure, and they help the neurons have the nutrients and energy that they need. But there are actually specific dopamine producing neurons in the very deep brain. And some of these areas are known as the substantia nigra, or black substance, because this black pigment or melanin builds up in these brain cells. And when people have died and donated their body either to autopsies, or when people have donated their body to science and they're undergoing dissection of brain tissue, it was shown many decades ago that there can be loss of this melanin or black substance in the substantia nigra. These are the actual cells that produce dopamine. And so when you lose dopamine production in these specific deep brain cells, this can lead to problems with coordinating movements, speech. It can affect sleep impairment. It can affect sleep function. People will have impaired sleep quality, fragmented sleep. It can gradually develop cognitive change. It can affect mood. One of the things that happens when you have a complicated system like the brain is that many of the same chemicals and signals that have developed are actually conserved, and they are useful in so many different strategies. The same way when we have different highways in the brain and different traffic signals, once you have a traffic signal that works, it could be affecting signals to various parts of the brain. So that's the reason why Parkinson's disease doesn't just affect movement. It can affect all of these things, including more than I didn't mention. It's not all just dopamine as well. There are other neurotransmitters that can be involved, including serotonin, acetylcholine, GABA, just to name a few. The picture on the right side of the screen actually shows a normal neuron, and you can see that there are lots of dopamine, tiny neurotransmitters that are released out of the ending of these neurons, and this can lead to normal movement. But if you have marked reduction in dopamine production from a diseased neuron or neurons that are dying, then this can lead to movement disorders, especially Parkinson's disease. It's been estimated that by the time you actually have even the beginning signs of movement problems in Parkinson's disease, that most people are 50 to 60% depleted in the dopamine that's being reduced by these neurons. So the future research that's happening, the research that's happening now that will hopefully be helpful in the near future, will be to try to figure out ways that Parkinson's disease is developing long before people actually have signs of a movement problem. So that if there were ways to arrest further progression of Parkinson's disease earlier on, we could actually change the natural history and the course and development of Parkinson's disease. So a lot of the research that's happening now is to stop or slow down this loss of dopamine producing cells. Parkinson's disease is not just a movement problem, as I mentioned. There can be many systems that are affected. Two of the systems that are commonly affected are mood and thinking. Fortunately, a lot of times this doesn't necessarily happen in the first few months or years of developing Parkinson's disease. But over time, they can definitely show up and they can affect quality of life. Sometimes can be a source of frustration, not only for patients, but their family members, loved ones, caregivers, because if you think about it, who you are, how you act, the way you think has a lot to do with how your brain works. And so because people with Parkinson's disease many times are not new to adulthood, we sort of have grown up. There's a way that you approach your life. You have a certain way that you handle things or the way you address things. There's a certain type of way that you function. And when Parkinson's disease starts to affect how people think or how their mood is, people who have never, for example, in their life had anxiety or depression or panic can start to develop some of these symptoms. And then it's very frustrating because they think, well, I've always been able to handle the stress in my life. What's wrong with me now? When it's really actually the neurological changes in the brain that are causing these symptoms. And it's not necessarily purely a mental health problem or a difficulty coping with stress. It actually has to do with hardwired to the highways and traffic signaling of the brain. And sometimes that's a frustrating source for people because they're like, I've never had these problems before. Now I feel like I'm having mental health issues. But it's all part of the disease process. And Parkinson's disease is not the only condition that affects the brain that can be associated with these changes. Parkinson's disease is a type of movement disorder because the tremors, the shakiness, the slowness of movement, or bradykinesia, the stiffness or rigidity in the joints and in the muscles that it can cause, all can impair movement. So movement disorders is sort of a broader term that encompasses Parkinson's disease and other similar conditions. Unfortunately, because there is a lot of variability, many people with Parkinson's disease feel surprised when they see other people who may have Parkinson's disease, but they're having different issues related to Parkinson's disease. And it may not be that one person with Parkinson's disease will develop all of the problems that another person has. But over time, usually these conditions can progress slowly, and you can start to see more change as the years and decades progress. So let's talk a little bit more about some of the movement symptoms. So many people, I think if you ask most medical students or people who are becoming doctors, what do you think of when you think of Parkinson's disease? They'll probably say tremor or shaking. And the truth is that only 70 to 80% of people with Parkinson's disease will actually ever have shakiness. There are definitely people with Parkinson's disease who don't have a lot of tremor. But when they do have tremor, a lot of times it may be at the end of a limb. It may be in their hand, it may be in their foot. Sometimes they can actually have it in their chin or in their jaw. They can have tremor in the head or neck, although a lot of times the people have a lot of head bobbing, yes, yes, or no, no movements. It may be that they have another tremor condition like essential tremor, which may be increasing the chances of developing some Parkinsonian changes. Movement disorder specialists can sort of sort through some of that and try to figure out more of what's happening. What actually is much more likely to affect people is slowness and trouble with movement. And this is sometimes called bradykinesia. Now, what sometimes is also confusing to non-Parkinson's physicians is that it's not always that people just move painfully slowly. A lot of times if a person is making repetitive movements, these movements can actually be fairly fast. But then what happens is if the movements become smaller with repetition, or if the movements become just lower amplitude, even if they still occur more quickly, a person overall will have lower mobility and they may have difficult time, they may have shuffling, they may have to take smaller steps. And so in the end, their mobility does become more impaired. And so that's a type of feature with bradykinesia. Stiffness or rigidity in the arms, legs, neck, hips, other parts of the body, trunk, can become more of a problem over time. And in fact, when I was a fellow at Baylor College of Medicine, the #1 presenting symptom in Parkinson's disease was actually shoulder stiffness. And many people with Parkinson's disease will say that they've noticed that for some time. Sometimes that may have even been going on for a year or 2 years before they started having other signs of Parkinson's disease. They've also done studies where people with Parkinson's disease were 3 times more likely to go to a doctor in the 5 years before they were diagnosed with Parkinson's for various musculoskeletal complaints that in the end were the early signs of Parkinson's disease, even if they didn't have all of these problems. Over time, usually not in the first year or so, people can develop more problems with walking and balance. For those people who are having a lot of problems early on with balance, especially in the first year, 2 years, 3 years, they may have a different type of Parkinsonian condition. And that's where being evaluated by a movement disorder specialist can help pick up some of those subtle signs and try to get the right answers as early as possible. Well, what about some of the other non-motor things? I mentioned mood or mental health. People can start to develop sadness, apathy, depression, anxiety, nervousness, fear. And these are all very frustrating. You know, this picture here sort of shows an iceberg. And when we think of an iceberg, we think of the towering cliffs of ice, but that's just the tip of the iceberg. There's a lot that happens underneath. And so for any of you who are familiar with the story of the Titanic or have seen the movie, you know, an iceberg is a very good analogy for this because there are so many things that we see outside of a person, but there's a lot that happens inside. People over time, even if they're not fully disoriented, like when people think of cognition, they sort of think of dementia, but it's usually a lot milder than that, especially earlier on. People may have problems paying attention or learning new things. They may not be able to sustain their attention for longer periods of time. They may feel that their thinking is slow or less coordinated, which is a lot like the movements being slower and less coordinated. They may have a hard time remembering words or names, although I have to admit, a lot of people over 60, even if they don't have a progressive neurological condition, will often admit to me that they're not as sharp at remembering words or names as they used to be. But people can have a softness or quietness of their speech. They may be likely to have a difficulty maintaining sleep. They're waking up more in the middle of the night when usually they used to be able to sleep through the night, or they may have more problems falling asleep. There are also people who can act out dreams. They can toss and turn. They may even get up and do sleepwalking. And so this can be REM sleep disorder. Sometimes this can actually predate the beginning of motor symptoms in Parkinson's disease by even 10 or 20 years. They can often describe that they have loss of energy. They can have fatigue. They can feel tired or drowsy or sleepy during the day. They may not be able to get as many things done during the day as they had before. And this goes back to multitasking, scheduling, changing how a person has their daily routine. This can be a source of frustration for people. Constipation, not just straining or having difficulty evacuating the bowels, but even just slow bowel transit. So people end up having sometimes less than 2 bowel movements per week, when in many cases they were having bowel movements several times a day, or at least once a day, or maybe not more than once every couple of days. Hallucinations are unlikely to happen early on in Parkinson's disease, but over time, especially as people are living longer and having a better lifestyle and being able to maintain their health for many years to decades, over time, people can become more prone to either illusions or seeing things that aren't there. Initially, they may be very aware that these hallucinations are not real, but then over time, they can end up losing insight, and then they feel fairly sure that there are strange people in the house, or that they are, you know, animals in the house, or other things that aren't there. And this can be a source of disagreement with other family members and caregivers. So what are 10 early signs of Parkinson's? I mean, this is not an exhaustive list, but these are some things that when you see these, I hope that people will be thinking about, could there be a possibility of Parkinson's disease? I mentioned tremor, but what about small handwriting? That smallness or slowness of handwriting can lead to a smaller print. Many times, because the tremor is not at is only at rest, as people are doing their handwriting, the handwriting may not be that shaky. So if there is tremor with handwriting, sometimes that can be a sign of essential tremor or other tremor conditions overlapping with Parkinson's disease. Losing sense of smell can be, 4 to 8 years before motor symptoms. And sometimes this isn't that noticeable until other people say, well, do you smell that? And then people can't smell something. Trouble sleeping, and there can be many contributors to that. Problems with overall mobility or walking. And there are certainly musculoskeletal problems that people can develop as they get older, including arthritis of the hips and knees and lower back that can affect mobility and walking as well, even if they don't have Parkinson's disease. I mentioned constipation, a soft or low or quiet voice. Many people will often develop loss of movement in the face. And this has been described as a masked face. One thing that many people with Parkinson's disease complain about is that people can't read them anymore, or they think they seem sad or angry when they feel just as happy or jubilant or outgoing as they normally had before, but because of the masked faces, that people misinterpret that. Dizziness or fainting can also happen, especially if medications are making people feel dizzy, or if there's a problem regulating blood pressure, where people can sit up or stand up, and then the blood pressure can drop. Orthostatic hypotension can be a problem in Parkinson's disease, especially in the hot summer where people are more likely to get dehydrated, and they're also not regulating body temperature as well. They can be more likely to have syncope or passing out. Stooping or hunched over. We sort of think when we see somebody who's hunched over that might be related to age, especially if they have a lot of changes in their spine, in their neck and middle and lower back. But a lot of times, even just the involuntary pulling of muscles, which comes from the deep brain, a sort of dystonia, can make people hunched or pull or have their angles become more acute so that they are not as mobile. So how is Parkinson's disease diagnosed? One of the things that sometimes is surprising for people is that they go to a neurologist, and the neurologist has them, touch my finger, touch my nose, checks their reflexes, has them walk, turn around, checks their posture, looks at their eye movements, puts them through the full neuro exam. And then even after 5 or 6 minutes of doing this neuro exam, says, I think you have Parkinson's disease. Well, this is frustrating because I just met you and you just examined me for a few minutes. How can you know that I have Parkinson's disease? There's no one way to diagnose Parkinson's disease, but actually doing a thorough and careful neurological exam and looking at a person's medical history is often very effective at figuring this out. One of the reasons why I chose neurology and then specifically went into movement disorders was it was actually pretty amazing that you could actually just examine somebody and take a history and actually fairly accurately diagnose somebody correctly, as opposed to people who have many medical conditions where we have to order a bunch of blood tests or do scans or wait to see how they do over time. It is true that over time, having that time history and elapsed course can more accurately solidify a diagnosis. But there are many situations where I can meet a person and even in a few minutes be able to, with confidence, feel that I have an accurate diagnosis. And some of that is being familiar with the subtleties. But a lot of times if physicians are not explaining what they're finding, it just sort of seems like they put people through the process and they figured it out and that's it. And now you have Parkinson's disease. So sometimes people feel like they're unsure that that might be the diagnosis. Being able to put the process together isn't that hard, but there are certain assessments that movement disorder specialists can do, like the Unified Parkinson's Disease Rating Scale, which is often used in research projects when it really matters whether people have Parkinson's disease or other types of disorders. But they can also try to see how people respond to Parkinson's disease medications. And that can also help provide some validity that, yes, this does seem like it's Parkinsonian in nature. There is something that is a brain imaging scan called a DAT scan. It's actually a special type of PET scan. So it's not an MRI or a CT scan. And you can actually measure and see whether dopamine intake very deep in the brain is diminished or not. But this is not actually usually necessary to confirm a diagnosis of Parkinson's disease. And to make things even more interesting, there have been some people who actually look like they have Parkinson's disease and they respond to Parkinson's medicines. But then when we do DAT scans, it turns out that they come back normal. And so, what's going on there? So there's a lot of overlap, and this is something that actually is still being ironed out. But being able to put the whole picture together is often helpful at trying to figure out the process. So when should people start treatment for Parkinson's disease? This is actually a highly individualized process. There are definitely people early on who, if they don't feel like the symptoms are troubling to them, if they would rather hold off and not start on medication, that's perfectly reasonable. There are other times where people are very busy and active. They're concerned that maybe the slowness of movement or even the tremor or the stiffness that they're experiencing is going to affect their ability to function at their job. And they want to be able to start treatment so that they can continue to maintain gainful employment, be active, be able to do all the things that they're trying to do. When you think about how the average age for Parkinson's is somewhere between 55 and 60, there are many people who still have 5 to 10 years left of a normal career, and they're hoping to be able to continue to work and finish that on time and not have to become disabled or stop their employment early. So some of that is understanding what sort of tasks people have, what type of functions, whether they're working or not, that they would like to be able to do, and individualizing that treatment. It is a very important discussion between a neurologist and the actual patient. And family members and caregivers can also frequently weigh in on that discussion. The goal of treating is to really manage symptoms so that people can live well. I have seen people postpone treatment for months or years, probably beyond when they could have started treatment, and it was really affecting their quality of life. They had a hard time moving, they couldn't go places, they couldn't do things, but they wanted to wait and delay therapy. And some of that is, it doesn't have to be that way. Treatment depends on each person's symptoms and their personal needs. At different points in the Parkinson's journey, individuals may need to seek the support of professionals who can help with treatments and symptom management. I have seen many people just start out under the care of their primary care physician, and that's great if that person can help you. But we want people to realize that movement disorder specialists, general neurologists, various types of nurses and therapists, including speech therapy, that can often be helpful in this process. Having a psychiatrist or a psychologist can often be helpful. And many people tell me routinely that they wish they would have taken advantage of these resources sooner because they definitely feel like they're doing better, or they didn't realize that there was a good role for that when they had Parkinson's disease. So I think it's important that we're talking about that in a one-on-one talk. Having pharmacists who are very familiar with the medications and the interactions can also be helpful. Social workers are great at connecting people and resources. And that's true. We have people like Kim at the Parkinson's Foundation Heartland, but even different health systems and different movement disorder centers have access to people who can connect you with resources as well. So there's no shortage of these people to try to help coordinate care. Just realize that you have access to all this. Finding a qualified physician is a first step. When you think about primary care, and I work with and educate medical students on a daily basis, as Kim pointed out, if you think about a primary care physician, they may have only had a total of 2 to 4 weeks of neurology training in their entire career. Some residents rotate on neurology services, some do not. Some medical schools in America do not have any required neurology rotations. Others, like the University of Kansas, they have at least 4 weeks. So, being able to say, this is not something I'm super familiar with, we need to get you the right care from people who have specialty training and subspecialty training is sometimes half the battle. If possible, and I'm biased because I'm a movement disorder specialist, but a lot of what we learn are strategies that are going to give people an extra 10, 15, 20% on working and addressing the things that maybe people didn't realize were even a part of Parkinson's disease. If you are trying to find a specialist in Parkinson's disease in your area, I know we have a lot of people from a variety of states around the country who are listening in. There's the toll-free hotline and helpline from the Parkinson Foundation, 1-800-4PD-INFO or info. And the numbers there, if you prefer numbers, 1-800-473-4636. They can definitely try to connect you with people as close to you as possible so that you can get the type of care that you need to help manage this. Parkinson's treatments are not always about medications. There are motor and non-motor symptom medications that are available, but there are also surgical options for some of the motor symptoms as well. Therapists can also help coordinate specific exercises, different types of therapy, including physical, occupational, and speech therapy. Counseling and other therapy can sometimes be available from social workers, psychologists, and even medication management from psychiatrists. All of this is very appropriate, and to be able to say, I've heard about what these therapies are, I think I want to try this, or that all sounds good right now, I don't think I need that right now, but maybe in the future. That's all that we ask, is that people become familiar with these opportunities. People with Parkinson's disease can take a variety of different medicines. There can be different doses, there can be different times of day in order to manage symptoms. The most effective medicine still, after the last 60, we're almost 60 years now, 55 years, is levodopa. It comes in different formulations. Levodopa is the chemical in the medication that is actively converted to dopamine in the brain. There are other supporting medications that are often used, including dopamine agonists. These are medicines that go to dopamine receptors in the brain and stimulate those receptors. It's like pushing buttons. They're activating the process. So it's almost like a substitute teacher, being able to cover in areas where the dopamine is low. Monoamine oxidase B inhibitors, these are actually medications that block an enzyme that normally breaks down dopamine. So if you already have less dopamine in the brain, at least we can get better use out of the dopamine you already have, because it continues to have action. And then catechol-O-methyltransferase, or COMT inhibitors, are a different class of medications for Parkinson's that can increase the benefit of levodopa, because this blocks another enzyme that is involved in breaking down dopamine. Well, what about surgical options? Surgical options can be explored if symptoms are not well controlled with medication alone. If people have a reasonably good response to levodopa, then sometimes if they're having a lot of problems with motor fluctuations throughout the day, or if they have too much medication on board where they're having levodopa-induced dyskinesias, having a nice steady electrical stimulation can help reduce the amount of medication needed to control symptoms. This usually is going to be effective when people do respond to levodopa. So if you have not had a good response to levodopa, deep brain stimulation is less likely to be helpful. Duodenal levodopa, or enteral levodopa, is another option, or called duopa, where a person has a feeding tube placed in the stomach, and then a pump actually pumps carbidopa-levodopa gel very evenly throughout the day and night during the waking day to deliver the medication directly to the intestine. So this bypasses some of the food and protein interactions with the medication, so that if people are having a hard time having stable doses of dopamine during the day, it can sort of level things out. And this is also to treat motor symptoms. Obviously, surgery is not right for everyone, and that's true in Parkinson's and even many other conditions. Being able to have a reasonable discussion with your doctor about whether this is a good option or not for you is half the battle. People with Parkinson's disease who start exercising very early after their diagnosis, especially for a minimum of 2.5 hours per week, seem to experience a slower decline in quality of life in comparison to those who start exercising later. You have to go in with the idea that this is helpful for your brain. Otherwise, we know that when we think about things like heart attacks, cancer, stroke, there's so much evidence that exercise is helpful. This by itself has not been enough to help convince people that we should exercise this much. So if you have recently been diagnosed with Parkinson's disease, or you're even several years into this, it's not too late to start and be engaged, and you'll release more dopamine in the brain, many other aging processes that are accelerating in the brain. There are a variety of different neurological studies looking at this, including the Parkinson's Outcomes Project. Exercise helps maintain balance, mobility, strength, and flexibility. It may also help to ease some other secondary symptoms like mood and constipation. One of the theories that comes up in why people don't like to exercise is that a lot of times when you start exercising, those first few minutes, you actually are releasing more adrenaline and epinephrine in the system, which actually causes some imbalance in some of the neurotransmitters. And this actually makes people not feel well. But for those people who like to get up at 3 o'clock in the morning and go on these runs, and it releases dopamine in the brain, they get the runner's high. Others neurotransmitters besides dopamine actually are also released. They're sort of feeling the good benefits of neurotransmitters. And so if you sort of know that the further you get into the exercise, 15, 20, 25 minutes, that actually you will feel better and you will actually have a better mood and you won't feel as stiff or sore. It's proof that a lot of this is actually brain chemicals, because if it were really your arthritis or muscle stiffness, you would think that more exercise would actually make that problem worse. But people actually start to feel better as they progress into the course of their one exercise treatment. So exercise programs should include flexibility and stretching exercises. Aerobic activity works on the mitochondria to channel some of those energy molecules through pathways that wouldn't normally happen at rest. Resistance training can also build strength in muscles. So even the problem with motor control is deep in the brain. If you have better, healthier muscles, people can adapt better to those changes in Parkinson's disease. A variety of activities. Doesn't have to just be walking. Biking, including recumbent biking, running for people who don't have balance problems, Tai Chi, yoga, Pilates, dance, weight training, non-contact boxing, Qigong, the list goes on. Do whatever you will stick to and enjoy. Some people actually get bored doing the same types of exercises and trying to change it up. So that's definitely something to keep people engaged. I mentioned a little bit about the different types of therapists. Physical therapists often overlap with occupational therapists. The goal is to really try to keep people moving as well as possible, as long as possible, and enhance your ability to move. And this may actually help improve some of the symptoms of Parkinson's. Occupational therapists can also help people identify strategies to help you continue doing activities that are important to you. You can use adaptive equipment. They can help you to work to your personal strengths and avoid weaknesses, how to change your environment, how you can change how you are doing your activities. And then speech and language pathology isn't just about articulation or voice. It's also communication skills, cognitive issues, swallowing difficulties. Having some sort of early intervention is often important. So having a baseline evaluation after a recent diagnosis can be helpful, even if you don't think that you would benefit right away from the course of a speech therapy cycle. Depression and anxiety are the #1 factors impacting the overall health and well-being of people with Parkinson's disease. Being able to work with social workers, psychologists, psychiatrists, getting that support that is helpful for people to treat mood disorders, discuss the challenges of living with Parkinson's disease, build coping skills throughout the Parkinson's disease journey. Counselors can also be helpful. And sometimes it also can involve family, friends, care partners, caregivers, being able to preserve and support the emotional well-being of the family or the other caregivers. Some of it is that people, the person with Parkinson's disease is only one part of the family who's affected. Sometimes people who are family members and caregivers are also traumatized by the development of this chronic condition. And they want to be helpful, but it's difficult to know what to do or what to say. And so going through this process can give people the resources they need to get help. Sometimes just the unpredictable nature of Parkinson's disease can be frustrating. I mean, there are so many successful people in this world, and they're used to having their routine and their regimen. And now you suddenly have to start going with the flow and being more laid back about things. And this can be frustrating and stressful for people, depending on how you feel on a given day. There are always things that you can try to take ownership of. Maybe you're in control just of what you can do exercise-wise, or maybe you can be only in control about how you think about your Parkinson's or your attitude each day. These are definitely things that can make a difference to improve that sense of control. Being and feeling more independent. What does being independent mean to you? Some people over time, especially if they have visuospatial problems or they're not as able to navigate well, it can affect their driving, for example. And then the keys are taken away, and then you're sort of frustrated by this loss of independence. What do you have in control what can you do to maintain as much independence as you can? Some of that can often be discussed with family members and caregivers. How do you reconfigure your lifestyle? Do you actually just cut out the things that are hard, or are there ways to still do the activities you want, but make adjustments? You know, maybe it's not realistic to be able to do a marathon for a lot of people if they've had Parkinson's disease for 10 years. Well, can they still be engaged in other running events or other walking events so that they still make adjustments to what's happening? Maybe it's hard to do mountain climbing, but they can still do hiking on a more level terrain. Some of it is sort of realizing what the alternatives are and making the best of the situation. How do you create new roles? If you retire sooner than you would have liked, what sort of other opportunities are there to volunteer or to be engaged in other meaningful things that are different than being gainfully employed, but that are still fulfilling and you're giving back to the community and able to make a difference? What does your identity mean to you? Many times people use terms to describe their own identity. So in my situation, I'm not only a movement disorder specialist and a neurologist, I'm also a husband, I'm also a father, I am a teacher, I'm a mentor to people. These all have meaning to me. What does your identity mean to you? And how, as things change, how can you look at things about how your identity changes? I once had a patient who didn't have Parkinson's disease, and he was a retired professor, and he said, I thought a lot about what it might like to be an old man, but I didn't think about what it would like to be an old man with chronic medical illness. And so this sort of anticipation is not something that many of us expect, but how can we adapt and look at things in a new way? Research has such a vital role. And as a person who's not engaged in extensive research, I help out with some of the research projects, but I have such admiration for the people in Parkinson's disease who not only are volunteering to be involved in research, but also are physicians and scientists who are actually trying to figure out all of these details, because that actually helps us work with patients and come up with new treatments and different ideas on how to help manage some of this. This is how we can figure out how symptoms and disease processes progress. And ultimately, research is what brings us closer to a cure. If you would like to know more, it doesn't mean that you have to sign up for every research project or even any research project. But if you would like to know more and you say, well, this is something I could reasonably do, or maybe it doesn't even involve a medicine. There are research trials just that are questionnaires that we want to understand more about what people with Parkinson's disease go through. You can go to clinicaltrials.gov on the internet or call the toll-free helpline that I mentioned earlier, 1-800-4PD-INFO or info, or visit online at www.parkinson.org/research. In conclusion, Parkinson's disease symptoms can be treated effectively. Many people don't realize that there are options available, and you can decide whether you want to participate in those treatment options. But if you don't have access to them or know about them, then nobody gets treated. Symptoms vary from person to person and can include movement and non-movement symptoms. Having a personalized treatment approach with a comprehensive team of providers can help individuals have the best long-term outcomes. And a support network is helpful, not only for the person with Parkinson's disease, but also their family members and caregivers. So with that, I'm going to turn it back over to Kim, who is going to coordinate some of the question and answer session.
I sure am. Thank you so much, Dr. Muhammad. And we do have a number of questions, so I'll jump right in. Can you talk about timing of Sinemet meds, particularly around meals and protein?
Absolutely. This is a great question. And I think if we asked our third-year medical students who are just rotating on neurology for the first time, what's a good starting dose for carbidopa, levodopa, or Sinemet? I would hope that most of them would answer 1 tablet 2 or 3 times a day. That's sort of what we expect a medical student to know as far as starting treatment. But everybody can have very individualized treatment. And what I've noticed about movement disorder specialists is they're not afraid to get into the nitty-gritty about a person's daily schedule, understanding how the medicine works, how long it takes to take effect, how long does it take for the medicine to last in the system, does it wear off, If a person is taking their medicine 3 times a day, for example, I know when people get admitted to the hospital, 3 times a day automatically to the hospital doctor means 9 a.m., 3 p.m., and 9 p.m. So if you're getting your medicines 3 times a day, 1/3 of your total daily dose is given at bedtime so that you can have the most mobile dreams ever. No, so this is not an effective way to dose it. We want to try to dose it during the waking day. And food and protein does matter. We often recommend that if you can take the medicine at least 20 to 30 minutes before a meal with protein, that's going to allow the medicine to be broken down and absorbed and not have protein drug interactions. You could potentially have 30% less medication absorbed simply from taking it with food. And sometimes we've heard of pharmacists telling patients, well, you can get some upset stomach or nausea with carbidopa levodopa, so you should probably take it with food. Take it with some plain crackers. If you get fancy and do cheese crackers or peanut butter crackers, save those for snack time. But if you can take something that doesn't have a lot of protein, milk, meat, cheese, these things can all interact with levodopa. If you want to take your levodopa after you eat, we recommend that you wait at least 90 minutes. So it's not symmetric. This is why a lot of times if people, even if they're starting off 3 times a day, if they can actually take it, for example, 20 or 30 minutes before breakfast, lunch, and dinner, that may actually cover them during the waking day. There are many people with Parkinson's early on, especially, who don't need a lot of overnight or around-the-clock coverage with carbidopa levodopa. And many people early on say, well, I just like to take it in the morning because I'm at work and it's functioning. And by the afternoon or evening, it's okay if I'm a little slow or have some tremor. And they may be on fewer doses a day. But also for people who are taking doses 4, 5, even 6 or 7 times a day, being able to navigate mealtime and snack time. I've definitely seen people over time save their protein for maybe 1 meal a day so that they're not having as many protein interactions. But this is a great and important question because it definitely impacts how people respond to the medicine.
Okay, thank you. A question on dyskinesia. Any new ways to fight dyskinesia?
So before we talk about new ways, I think sometimes people don't realize that we have pretty good old ways to treat dyskinesia. One of the things that often happens is trying to really sit down and individualize the amount of medicine people take. If you sort of have a one-size-fits-all approach to, okay, I'm going to take 2.5 pills 3 times a day, well, those 2.5 pills all at once may actually be putting people over the top and having a lot of dyskinesia. It might go better to take exactly the same amount of medicine and redistribute it a little bit more evenly so that you don't have as much in the system. But there are newer treatment options. In the last several years, there are 2 companies that actually have made an amantadine extended release medication to treat dyskinesia. There were some differences in how the medication was studied, but as long as people are not having side effects from the anticholinergic effects of amantadine, that may be an option earlier on. A lot of times, if people are having a lot of difficulty with dyskinesia, for people who qualify for deep brain stimulation, if you know you're getting a good response with levodopa, we can often cut the amount of medication people take, depending on what type of deep brain stimulator they use or where it's implanted. We can usually reduce the amount of levodopa that people are on by even 20 to 25%. And so that may not end up, they may not reaching the level where they have a lot of dyskinesia. So that's definitely, that's sort of an overview answer. This is definitely something that a movement disorder specialist can help you with if you're not already under the care of one. But there are some subtleties to how we can approach that.
Okay, thank you. A question on symptoms. Are night sweats a typical symptom of PD, and how common and what is the treatment?
Great question. And so this, fortunately, this isn't a common problem, but we do run into this from time to time. A lot of people are not aware that the levodopa itself, when it's increasing dopamine, there can be some problems with perspiration. That can be during the daytime, the nighttime, sometimes because of other circadian rhythm issues, as far as like body temperature and regulation. You know, the hypothalamus is an area of the brain that regulates a lot of this. and it sits very close to the connections with the brainstem and the deep brain, and thalamus. So people can start to have problems with that. But I want to caution people that there are many other medications that often are more notorious for causing night sweats. And so, for example, for people who may be having a lot of musculoskeletal pain in the setting of Parkinson's disease, they may be on various type of analgesic pain medications, including prescription opioids, whether things like hydrocodone, oxycodone, morphine, hydromorphone, codeine, to name a few. Some of these are actually very notorious for increasing night sweats. And then, like I said before, when you think about the age ranges of people who start to develop Parkinson's disease, it's super important that if you're having night sweats, you have a discussion at the very least with your primary care physician, because sometimes people have something else. And so, having worked in an office where we had an endocrinologist, there were many people who had a thyroid problem, or there were many people, they were having night sweats and shaking chills because they were developing a bone marrow disease or something like lymphoma. So it's not enough to just say, well, is this a symptom? That symptom often needs a discussion and a workup. And so if I had any family members who were having that, I would want them to be evaluated right away to see if there's something else going on. But there are other medicines that sometimes make that worse.
Okay, thank you. We've had a couple of questions about the COVID-19 vaccine and whether you are seeing any side effects related to Parkinson's following a vaccine.
So it's interesting because even though I'm not in Parkinson's clinic anymore, because I see people in the hospital, they often have a variety of illnesses going on. So the usual scenario with our medical students and residents is people have more than one thing, and each one of these can be contributed in complex ways. There are people who have said that after they had a vaccine, especially the COVID-19 vaccines, we've got Pfizer, we've got Moderna, we've got Johnson & Johnson. There may be other companies that are developing vaccines as well. A lot of people are sort of looking at some of the subtleties about, well, if you have this one or that one, are you more likely to have this side effect or that side effect? This is something that's still being, the studies are ongoing and the follow-up. You have to realize that all of this was went through very, very quickly, and that normally the studies happen much more slowly, but because of how many people are impacted by the pandemic, the advantages of getting people vaccinated seem to far outweigh some of the disadvantages. In general, we haven't seen a lot of tremor being worse. There are some people who have noticed that for a day or two, the same way they may have a fever or they may have a headache or other more common side effects after the vaccine, the cytokine release that happens as your body mounts an immune response to fighting not only the COVID infection, but even just the substances in the vaccine, that's the immune response you want. People can have tremor very briefly, but even they've studied this in essential tremor, and in general, most of the time, they're not having a lot of tremor. If you notice that you've had a vaccine and you are having more tremor, and it's persistent beyond a day or two, that's definitely something to bring up with your doctor and get checked out, because there may be other things that are going on.
I'd also like to put in a plug. Our timing is good. Tomorrow, actually, Dr. Michael Oken, the medical director for the Parkinson's Foundation, is doing a Facebook Live on this topic. So he will talk specifically about Parkinson's and COVID-19 and the vaccination. So I'll share some details at the end, but that is at 11 Central Time tomorrow on Facebook Live, so folks can jump on and hear what Dr. Oken has got to say.
And he's a great resource and very well connected. So I'm looking forward to hearing from him as well.
That is great. Okay, a person asking, if I don't have good neurology care near me, can I use telehealth?
Great question. So I can tell you just from the experience of the pandemic over the last year, I know at the University of Kansas, we switched to telehealth right away. So in April of the pandemic was when we started doing this. And so we do have movement disorder specialists available to do telehealth. Now, I will tell you that if you were my family member and I wanted you to have the best care, it would be worthwhile to have at least the first visit in person if you can. And the reason is, I mean, here we are today, we're having a very, I think, effective Zoom meeting, and where it's interactive and We're discussing all these things, but there are some things that a neurological exam are much better assessed in person. You know, being able to check a person's tone, being able to check reflexes. Usually, and there are people who are studying telehealth in assessing movement disorders, and some of the preliminary results that are coming out is that it's quite good at being able to look at a person and say, yes, you still look like you're having bradykinesia, or you look like the way you're walking is very similar to what we would see with Parkinson's disease. But if you are able to go to a facility and see the doctor the first time, follow-up visits for telehealth don't require a lot of close examination. Sometimes just addressing the issues is more important, being able to make medication changes or assess how things are going. But even if you only went once a year to get that follow-up exam, that's something that could be beneficial for your care, and then have telehealth visits in between. And many patients actually, even who don't have Parkinson's disease, have really enjoyed it, because even if they live in the big city, they don't have to drive over and deal with the parking issues and all the other problems. So telehealth is definitely here to stay. It's not going to be, they're not going to wrap it up in a box and put it away when the pandemic is over. There may be changes about how insurance companies work with all that. But if you are able to get evaluated, that would be helpful. But if your only issue is to just do telehealth, that would be better than not getting care. So I would encourage you to look into that option.
Great. I know you talked about the importance of physical therapy, occupational therapy, speech therapy. This is somebody noting that their functional mobility has declined, but their doctor's not prescribing PT or speech. So how does this individual go about getting it?
Well, if they only have one doctor and their doctor has not recommended it, I mean, I think the first place to start is to actually bring it up with the doctor. It doesn't have to be during the visit. You know, I've encouraged people in the past, if you reach out to the doctor's medical assistant or the doctor's nurse and say, I've been learning more about therapy in Parkinson's disease, and I would like to have a physical therapy evaluation. That may be something where they could put in a referral. It doesn't have to take up a visit time to do that. Some doctors only will do referrals or prescriptions if you come either face-to-face or do telehealth. But that's also where having somebody who specializes in neurology or movement disorders to coordinate that care could be helpful. I'm not aware of a way that people could just sort of initiate their own physical therapy referral. I know there may be some places where if a person presented to a therapy office and wanted to have an evaluation, they might be able to go through it that way. But normally the people are going to need some sort of a referral. And so some of it is also just asking those questions and providing that education. Sometimes a quick 1 or 2 page handout from the Parkinson Foundation, for example, outlining some of the details about therapy could convince a doctor that this is worth the evaluation. But that's all we can do. When we go back to 0 to 4 or 2 to 4 weeks of neurology training in a person's entire career, many times doctors are not aware of all of these subtleties and details. That's the emphasis that we're trying to make here, is that you can be empowered yourself to have that education and information and knowledge to be able to be your own advocate. And also family members and caregivers can be advocates for patients as well and say, hey, I was reading about this, and do you think that it would be possible to do this? I think most of the time physicians are not going to be like, absolutely not. There's no evidence that this works because I'm not familiar with any evidence. They're going to be very open to the idea, but sometimes it does require a little bit of encouragement or providing some information in a way that doesn't, make the physician feel like, hey, how come you weren't familiar with this?
Yeah, good old self-advocacy. That's great. This is somebody saying they are a family member of somebody recently diagnosed and looking for guidance on how do they best help.
Terrific question. There's so many things I could say about this. I think, first of all, when you think about what it's like for a patient to be told, you have Parkinson's disease, or I think that you have Parkinson's disease. We know from many research studies in other terrible conditions like cancer, heart attack, heart failure, that when people are told that they have this diagnosis, the processing of actually being able to listen and hear that information and what the doctor said after that approaches almost zero. So having a person at the visits or listening in during the telehealth visit to be able to take notes or write some things down or even just regurgitate and rehash some of the things that were shared can be very helpful. But many patients who are diagnosed with Parkinson's disease, they also are frustrated because they don't know what to do. And many very well-meaning family members and caregivers are like, we're going to get you on supplements and we're going to do yoga and we're going to do all these things. And it can be very overwhelming for patients. So one of the things that I've heard from Parkinson's patients over the years, especially if you have a family member or a loved one or a friend who has Parkinson's disease, it's a lot like, being a family member and a caregiver and a loved one. Be what that person needs. How do we be what a person needs? We listen, we look. People say 2 ears, 1 mouth. There's a ratio. And so being able to, and to ask questions, to just be like, what is it that you need? But also to be engaged and be there. Sometimes people become very stoic. Well, I'm doing okay, I don't really need anything. That's sort of an answer that is not that helpful, because there probably are things that this person needs. Maybe they're not aware of it yet. Maybe they don't, maybe they're in denial and they haven't acknowledged it yet. But for them to know that you're there for them and that you can coordinate some of this resource access. Are you the person who goes on the internet and goes to the Parkinson Foundation website or makes that phone call or coordinates those things? Many times the fatigue of Parkinson's disease, even further into the course, means that people are getting less done per day. What are the things that maybe that person doesn't enjoy doing, but they need to have done? Can you help with those things? Can you be the multitasker? Can you step up and fill the void? Sometimes we want to wait to be told, okay, well, how can I help? Let me know, call me if I can be helpful. Figure out what it is that they need, ask those questions, pay attention. There's a way to do it. You can be very helpful and instrumental. Behind every person with Parkinson's disease who is functioning well, there's often a small army of people who are helpful. There's usually one spouse or family member or caregiver who's helpful, but then there are often other people who are, picking up the slack and being able to be helpful for people.
That's a great reminder to all of us, I think. A question about, you touched on genetics. The question is, why would I do genetic testing for Parkinson's? And does it really matter if PD has a genetic cause, if there's no way to prevent it anyway?
That's a great question. And so if we go back to 13 years ago when I was in fellowship, and at the time, they only were sort of thinking that maybe 8 genes were involved in Parkinson's disease. Now there are actually over 40 that they think are changing in some way and interacting together. I know with this, and I'm actually very excited about this PD gene research opportunity, because even though at the University of Kansas, we are accepting patients, and I think that this study is actually looking for 7 of the most common genes. The reason why they're starting out with that number is because they're trying to see whether meaningful changes in what those, genes are just DNA, so it's a blueprint, and it gets read, and you make proteins from this, and these proteins do things in brain cells. And so they already have a pretty good idea of what these 7 proteins, these 7 genes are doing, but they just need more data. So they need people to be able to say, well, okay, what does your DNA look like versus somebody else? And how does that actually change the progression of the disease? I think we've come full circle because, in the old days, they're like, well, genetics is a small part of Parkinson's disease. Actually, there are many people who are probably having more than 1 gene mutation. And so having multiple subtleties building up and causing this may be having much more of a profound impact than what we thought. And as far as like, how is that going to help? Well, there are already different research studies going on to develop ways to interfere with this process. That's not 20 or 30 years away. It's tough to have an exact timeline, but I think it would be very reasonable to say that within the next 5 to 10 years, there may be very specific treatments. And if a person did have those particular genes, then you would automatically become a candidate for somebody who could potentially benefit from that. So it's not necessarily this donation to science purely where you're like, well, I just want to give back and make sure that people 10 or 20 or 30 years from now will be able to do better with their Parkinson's disease. There may actually be potentially meaningful mechanisms that are available for people even 5 to 10 years from now.
That is very compelling. That's a great answer, and kind of makes you stop and think. We have a question that kind of reverses what you discussed earlier about supporting your loved one with Parkinson's. And this is somebody with Parkinson's who says, what if your care partner acts like you're fine and just wants you to keep doing as much as you can?
So the problem is that when you look at just life in general, how many people before they have a diagnosis of Parkinson's are dealing with things like depression, anxiety, alcoholism, substance abuse, marital problems, family dynamic issues. I don't mean to bring up a lot of sad topics, but this is a reality for many people. And so then when you throw in, oh, by the way, now you have Parkinson's also, these are some of the struggles that are very real for people. And what I would encourage this person to do is to think about what sort of communication issues were there before all of this happened. Because if there was a baseline problem, then that's a problem that hasn't gone away. And in fact, the stress and difficulty and burden of having a family member with a chronic disease doesn't have to be Parkinson's disease. It could be any chronic disease. It can often be more difficult. So then the communication issues can become more of a struggle. There also is, going back to what I said about coping, there's also denial. And so sometimes the family member or the caregiver or the friend, maybe at some level they understand at face value that yes, this person has Parkinson's disease, but they don't really have Parkinson's disease, or I don't want to accept that they have Parkinson's disease. And that's their way of coping. Sometimes allowing that person to work through that is something that can change over time. It doesn't mean that 1 year from now or 2 years from now, it will be the same. Now, what do you do during that time? Do you feel like you even have a month or two of going through that with that person, when you feel like you need extra support? Remember what I said about a small army. Find resources and help from other people who can help. It may not have to be a friend. It may be somebody at the Parkinson Foundation Heartland. It might be a social worker, a counselor. Sometimes people end up making new friends. They end up joining Parkinson's support groups where they meet other people who are going through the same things. So when we put all of our eggs in one basket, that's more likely that the basket gets dropped and the eggs get broken. But there is a way to navigate some of this. And, it doesn't downplay that there's still a relationship there. That relationship may be very long-standing. If it is long-standing and it's worked for a long time, there's every reason to think that it could get better. But we have to give people their moment. And maybe that person who has their moments of denial and they go through that process actually comes back and breaks through it through communication and patience and time. And then they're actually able to be 3 times the caregiver that they even imagined that they could be. So we can't give up on people. Sometimes there's this tendency to just throw things away. And it's like, we live in a very disposable time. You drive through fast food and you throw the trash. It's not like that. We got to give people a chance and effectively engage them.
I like that. And just don't give up.
Don't give up.
We have a question asking whether the Parkinson's Foundation has resources and support for caregivers. This is somebody with no family in town and they don't feel comfortable leaning on local friends. And I will just assure you, we have a great number of Parkinson's resources, and I see we've just put those in the chat. But I do want to put in a little shout out to, in the month of May, we are all about care partners. We'll be doing a virtual Care Partner Summit. So you'll have a chance to engage with other caregivers around the country on Mondays, Wednesdays, and Fridays throughout the month of May. So keep an eye out for that, parkinson.org/summit, and join the Care Partner community there. I have what I think, Dr. Muhammad, will be our last question. We just wanted to talk about, since you are in the hospital setting, can you talk about some of the unique concerns for a person with Parkinson's when hospitalized? We often find it's not something people sit around thinking about, but ultimately, a lot of us have a hospitalization. So, what are the unique things that our community needs to have in mind?
Absolutely, I'd be happy. This is actually the top part of Parkinson's that I'm probably the most familiar with. For those of you who I know from my previous job before I came back to the University of Kansas, even though I had a clinic more often, as opposed to now where I have no clinic, I still spend most of my time covering the hospital. So over the last 12, 13 years, I've done mostly hospital work. And so you get to meet a lot of people who are at a low point. I mean, nobody uh, would love to come to the hospital voluntarily if they didn't have a reason to, whether it's an acute medical illness or some sort of planned surgery. But for those of you, I hope none of you need the hospital, but ultimately people with Parkinson's disease are 6 times more likely to end up being hospitalized for various things. It could be fractures from a fall. It could be the development of a bladder infection or aspiration pneumonia. Fortunately, these things don't usually happen early on in Parkinson's disease, but over time, as people become less mobile for any reason, you think about things like multiple sclerosis or Huntington's disease, we run into some of the similar issues. People can have become dehydrated, they could go into kidney failure, they could end up in the hospital. They may end up needing surgery. An elective surgery would be preferable to an emergency surgery. But many people who are hospitalized with Parkinson's disease, they're in a completely different environment. Thinking about what I said earlier about trying to be in control of your situation. Being a hospitalized patient is like being completely out of control. You're surrounded by all these nurses and doctors and people who care, but they bring the medicines when they're ordered, not when you need them. Or they end up needing to have you not eat for so many hours because they need to give you time to rest, your GI tract to rest so they can do some tests. Or maybe they're going to do surgery tomorrow and you're not going to eat after midnight. So there are a lot of very specific details about how to get through your hospital stay so that you can get better, go home, be able to recuperate more quickly. And some of that involves the Aware and Care Kit, sponsored by the Parkinson Foundation. And so this is a program that's been going on for several years. And as Kim is demonstrating, she's got the kit right there. This is actually something that is available for people with Parkinson's disease to be able to have. And you can actually take it, some people keep it in their car. And so if they did need to go to the hospital, it's sort of readily available. But it has a variety of helpful information and strategies for people who are in the hospital. Sometimes people with Parkinson's disease, especially if they have more cognitive impairment, or hallucinations or psychosis at baseline, their delirium and their confusion can be worse in the hospital. And so there are still valuable pieces in the toolkit for family members and caregivers. I know one of the things we've run into with the COVID-19 pandemic is many health systems are limiting the number of family members and caregivers who can be present. For a long time, if people were positive, they wouldn't have any family members there. But now a lot of places are allowing either 1 or 2 family members to be present, and that could be very helpful, even if people come for a short period of time during the day to visit. But it can also help doctors and nurses who are not familiar with Parkinson's disease to have the information they need to be able to coordinate things to make your hospital stay at least more manageable. It's not a hotel experience. It's not just customer service. Some of it is just trying to be familiar and anticipating some of the usual complications. And so the Aware and Care Kit is a good place to start. I hope you won't need a lot of hospital care, but for people who do, there are some strategies that can be helpful.
Great, thank you much. And that too is available through our helpline with a lot of the great tools that Dr. Muhammad spoke about there. So with that, we do want to extend our warm thanks to you, Dr. Muhammad, for sharing your time and knowledge today. We want to let everyone know your feedback is so vital to what we do in our future programs. And so we do ask you to stay on for just a moment afterwards to complete a short survey that will open up in a new window on your screen after we wrap here today. Keep an eye out for an email with the resources and recording from today's program so that you can rewatch anything that you may want to. And we do recognize there are questions that may not have gotten answered today. Know that you can contact our Parkinson's Foundation helpline or ask your healthcare provider. I want to again thank the sponsors for today, our platinum sponsor, Boston Scientific, and our silver sponsors, Acadia, AbbVie, Accorda, Neurocrine, Kyowa Kirin, and Synovian. Please don't forget to visit them on our webpage after the program. We also have a brief message from our sponsor, Boston Scientific, before I share some final details about upcoming educational programs.
Life before DBS was a struggle. I was living my life around the medicine, and DBS has totally changed my life.
Thank you again to our sponsors. And for everyone to stay engaged in the community, we hope you'll join these upcoming programs. As we said, tomorrow, the Facebook Live regarding life with PD after COVID-19 vaccine, 11 a.m. Central. Then on May 1st, Moving Day, Kansas City. Parkinson's Revolution on June 12th. I want to remind everyone too about our PD Health at Home programs. Those take place every week of the year. It's a series of online programs with a Mindfulness Monday, Wellness Wednesday, and Fitness Friday. Lots of great content. We have some fun ones coming up. You can see next week, there's a brain games, more of a social interaction one next Wednesday. So check those out if you have not at parkinson.org/PD Health. And PD Health at Home is presented by the Light of Day Foundation. So we appreciate their generosity in making those programs possible. And finally, April is Parkinson's Awareness Month. So we have a lot of great resources to help you build awareness about Parkinson's and take a quiz to test your PD knowledge and become eligible to win some great prizes. Be sure and check that out. So this does conclude our program. We want to thank you all again for joining us, and thank you to Dr. Muhammad. We hope to see you soon at one of our programs. Please take care.